Hello again. Let's continue on with normocytic normochromic anemias. And we'll talk about two. Number one, anemia of chronic disease. Another name for it is anemia of inflammation. But I think anemia of chronic disease is used a little more commonly. And the second one would be aplastic anemia. So some causes of anemia don't change the size or the shape or the color of the RBCs. And so they get classified under a normocytic normochromic. So when somebody has a low H&H, and then you take a look at the MCB and the MCH, they're normal, but they can still have an anemia. And these would be the two important ones that we're going to discuss here. So let's start with anemia of chronic. Begins to acutely occur during virtually any infection or inflammation. And there's three mechanisms as far as pathophysiologic changes that occur in the body, the causes of them have been identified. Number one, slightly shortened red blood cell survival occurs via unknown mechanisms in patients with cancer or chronic infections. Granulocytes, which is the white blood cell, the granulocytes. So the red blood cells don't survive as long, and this happens because of cancer, chronic infections, and these red blood cells get killed too soon. Erythropoiesis is impaired because of decrease in both the production and the bone marrow's ability to respond to EPO. So if there's some type of a process going on here, obviously the person's going to be anemic and they're not going to be making many red blood cells. So this is very classic with chronic kidney disease. Now, okay, and then the third is intracellular iron metabolism is impaired. Somehow they have iron stores, they have enough iron, but it can't be released or it can't be used. So those are some things that can occur. So any of these three things right here that we talked about can lead to anemia. What happens? No, I'm not even going to tell you that. That's too much. We'll move on. So anemia of chronic disease is usually in the mild to moderate range. Individuals may even be asymptomatic, or the anemia may be a chance clinical finding. It's just incidentally found on lab. If there's a significant drop in the hemoglobin levels, clinical manifestations of anemia are going to appear. So if they do have low H&H, they're going to have symptoms of anemia, which are the general symptoms that we talked about. So the anemia of inflammation or anemia of chronic disease, use of erythropoietin in the treatment of this type of anemia, again, common in a chronic kidney patient. The erythropoietin that we give them parentally will be helpful in making more red blood cells. The principal treatment is easement of the underlying disorder. Basically, you just treat what the problem is. Is it a problem? Inflammation? Is it an infection? Is it a chronic disease? You just treat that because there's not a whole lot we can do. But in the meantime, we replace iron. If iron needs to be replaced, we can give red blood cell transfusions if that's something that needs to be done. And this is not anything I want you to memorize. I just kind of wanted to bring this up and show you. And this is the anemia of chronic disease and the iron deficiency anemia. And remember, these are some blood values that we talked about. So the reason I have this little chart here is to tell you that iron levels tend to be low. Serum iron levels tend to be low. Obviously, we know in iron deficiency anemia, but also in anemia of chronic disease. Remember, it's not a shortage of iron, but there's a utilization problem of iron. Total iron binding capacity basically just shows us the amount of transferrin in the blood, the ability to transfer. Okay, that's not super indicative of diagnostics at this point. The transferrin saturation, and here's the thing right here, the ferritin. So I told you to make sure we know the serum iron and the ferritin. Those give us a lot of information. Your stores. If somebody has iron deficiency anemia, they have no stores. Their gas tank is empty. But in anemia of chronic disease, they have low irons, and you think, oh, wow, they need an iron supplementation, and they may to increase the serum iron, but their iron stores are super high. It's just they're not being used, so they have high ferritin. So we tend to be careful about replacing iron when somebody has high iron stores. If their iron is low with high iron stores, you kind of have to think one step further to see what's going on. The next one is aplastic anemia. And aplastic anemia, I have a lot of writing here because I just wanted to use the one slide for it. So it's a hematopoietic failure of the bone marrow. Something's going on in the bone marrow, and it leads to a reduction of effective production of mature blood cells, resulting in a term I want you to know, pancytopenia. Pancytopenia is a decrease in all three of the major blood cells. And you can see right here, there's a problem in the bone marrow. And with that failure of the homopoiesis in the bone marrow, we have low white blood cells, low red blood cells, low platelets, anemia, neutropenia, and thrombocytopenia, which is a reduction or absence of all three of those blood cell types. What are the causes? Well, it can be just incidental. It just can be what I'm trying to say, like idiopathic. We just might not know. Could be autoimmune. Could be some medications, treatments. Maybe somebody has a virus. Chemicals is something that can certainly cause aplastic anemia. Medications like a chemotherapy that kills blood cells, right, can cause it. It could be something that's genetic. So there's multiple causes. Onset may be insidious, sudden, and severe. Manifestations. So let's take a look at this. How do they manifest? We draw their blood count, and they have low red blood cells, low white blood cells, low platelets. So hence, because of the anemia, they're weak, they're pale, they're dyspneic. Because of the leukocytopenia, they have recurrent infections. Because of the thrombocytopenia, they have a propensity to bleed. Diagnosis, a complete blood count, and this has to be confirmed by a bone marrow biopsy. Go in there and aspirate that bone marrow and take a look at it under the microscope. Treatment, we just want to identify and manage the underlying cause. If they need oxygen, we're always going to give them oxygen. If they have infections, we're going to give them an infection treatment, bleeding precautions if they have thrombocytopenia, blood transfusions if they're severely anemic, possibly, depending on the cause, maybe a bone marrow transplant to get them some good bone marrow that can produce some good red blood cells and all blood cells. So know in general what aplastic anemia is, pancytopenia, what they would look like. Okay, that's kind of a concept that I want you to know. So I'm going to go ahead and move on in this PowerPoint. I'm going to go ahead and talk about sickle cell anemia. So we're done with the anemias that this is not an aplastic anemia. Sickle cell anemia is actually referred to as a hemolytic anemia. So remember, hemolyze, when something hemolyzes, something's causing the red blood cells to break down. So sickle cell disease is a group of autosomal recessive. So it's a genetic mutation. Remember, autosomal recessive, they need one gene from each parent, and then it gives them a 25% chance of getting the disease. Disorder that's characterized by a production of an atypical type of hemoglobin, which is referred to as hemoglobin S, the sickle hemoglobin within the red blood cells. So you can see this picture here. We have the normal looking red blood cells, and then in here are these deformed type of atypical red blood cells that take on this sickle shape, hence the name sickle cell anemia. So remember, it's a hemolytic anemia. So there is a premature destruction of red blood cells. There's different types of hemolytic anemia, and the only one we're going to talk about is sickle cell anemia. Sickle cell is a lifelong disease. Abnormal erythrocytes, these sickle red blood cells, carry less oxygen. Key. This is a problem for them. You can't carry oxygen because it's not that really nice concave disc-shaped pliable red blood cell that we need. And because they're a funky shape, they clog the vessels. And when they get stuck in the blood vessels, what's going to happen to the tissues beyond the blood vessels? It's going to cause hypoxia. It's going to cause tissue ischemia. And wherever they kind of get stuck and clogged up, it causes them severe pain. So pain is a characteristic of this. It's a lifelong disease, something that they have for the rest of their life. It's more common in people of African and Mediterranean descent, and also seen in people from South, Central America, and Caribbean, and the Middle East. Again, this is something we do not see in Caucasians. And it's generally in people that have been historically from areas that have malaria. So it protects, like this sickle cell trait originally is thought to protect somebody against malaria in these areas that are common with malaria. And the sickle cell becomes a hostile environment for that parasite when it gets into their body, and it eliminates that malaria. And hence, that's how that gene has come about. Just a little fun fact, kind of interesting. And that's why this group of people are the people that we see sickle cell anemia in. So it's triggered by a stressors. That's important to know. So what are main stressors for somebody with sickle cell? Well, decreased oxygen. They become hypoxemic. Why? Because these blood cells get stuck in these vessels and they start getting tissue ischemia. Acidosis. What could cause acidosis? It could go into a respiratory acidosis. Maybe they're diabetic and they're making ketones, so they're in a metabolic acidosis. A lactic acidosis can cause a acidosis. Somebody who smokes and as a COPD patient, and they're in a chronic respiratory acidosis, so that is another trigger. Low plasma volume, most specifically dehydration. They become dehydrated. Then when they become dehydrated, those little sickle cells get stuck in the vessels. And low temperatures, cold temperatures can also be a trigger, obviously because of the vasoconstriction, and so hence it the sickle cells get stuck in the vessels. The clinical manifestations of sickle cell can vary. Some individuals may have mild symptoms, and others may just suffer from repeated vaso-occlusive crisis and have a sickle cell crisis frequently. So again, they can have a mild, moderate, or severe. The clinical manifestations of sickle cell disease usually do not appear until the infant is at least 6 months old. So this is something that is diagnosed in a child. They used to have a high infant death rate, and not anymore. So we screen for this, and went for in all infants, and the treatments have really been pretty progressive now, and so they live well into adulthood with no problems. But their complications can be life-threatening. Remember, they can have this ischemia, they get frequent infections, they could have some kidney damage because of the poor blood flow that might go to their kidneys. They can have bone and joint pains, these type of abdominal issues, lung issues, clots, hemorrhage in the brain or the eye, or the lung or the heart, right? Spleen, just any kind of complication can occur based on those blood cells lodging into an area. Okay, so for evaluation, we can do a lab test for them, and this lab test is now included as part of a routine newborn screening in all 50 states and the District of Columbia. So somebody should not go for any amount of time and not be diagnosed with this. The treatment, there's no cure, but they are getting close. They're just really close to a cure, and the treatments are pretty sophisticated right now. So again, it's improved, and the main kind of goal of treatment, we want to relieve their pain, and we want to prevent any of those complications that we just saw in that previous slide. So avoid crisis, avoid fever and infections, acidosis, dehydration, constricting clothing, exposure to cold. So we want to avoid any of the triggers. Frequent infections can occur because this involves the spleen. The spleen's always working overtime to try to clear out those broken down red blood cells. So hence they can have a poorer immune system. So infection is a problem for them. So antibiotics is part of their treatment. Should put vaccines here. It's important that they get their immunizations. Obviously, oxygen is a mainstay treatment because of their hypoxia. Pain, they're going to those sickle cells get stuck in the vessels and they have excruciating pain because of the hypoxia of the tissue and the ischemia. Fluids, we want to give them fluids, get that blood moving, push that blood through the vessels. Maybe they have a lot of the sickle cell red blood cells and not the normal ones, and the spleen is trying to clean them out, and so they're severely anemic. They may need a transfusion. And then there's a medication called hydroxyurea, which I'm hoping you're familiar with. It's basically like a chemotherapy pill, and it is given to patients with sickle cell. It's given to patients that have leukemia. It's given to patients who have polycythemia vera. And it has an anti-cancer effects. And basically in sickle cell, it keeps the red blood cells from sickling and keeps them from changing that shape and makes them more flexible instead of kind of stiff and hard. And that will help prevent and reduce symptoms in that patient. So many of them are on this medication. And this medication, unfortunately, is not typically used in pregnant women. So let's move on now. We're not going to talk about anemia anymore. I'm going to talk about polycythemia vera, which is now not too little RBCs, but too many RBCs, okay? So abnormally high erythrocytes. Hematocrit is high, not low. Generally, when a hematocrit is greater than 50%, that is a definition of polycythemia. Now, there are more specific, it's a little lower in women, maybe 49 for men, 48 for women, but I think just in general, if you remember 50%, it's often a landmark kind of a guideline that's used. Polycythemia vera, okay, we're going to talk about two things right here. Polycythemia vera, which is like a primary polycythemia, and polycythemia, which is a secondary polycythemia. So let's talk about this first one. Polycythemia vera is slowly growing blood cancer, which the bone marrow just makes too many red blood cells. It's quite rare, with a peak incidence between the age of 60 and 80 years old. Can be considered a neoplastic disease, which is cancer. Increased blood volume and viscosity leading to tissue ischemia and necrosis. So again, all these red blood cells, so the blood becomes very thick and viscous, and it gets stuck in the vessels. They're not sickle cell shape or abnormal shapes. There's just too many of them. More than 95% of individuals with polycythemia have an acquired mutation in the JAK2 gene. So this is, I don't talk a lot about genes, but this is one gene you want to kind of tuck away that does play a role in different types of neoplastic disease, and it plays a role in this right here. So 95% of the individuals. So this is something that is genetic here that can be inherited, this type of polycythemia vera. Complications, you can kind of think, what would they be? Well, they got this thrombosis, they got big blood clots, and they're going to have high blood pressure because they got all these red blood cells that are pushing on the inside of the artery, and it can cause them to have heart failure with all that sludge moving through, bleeding, splenomegaly, because the spleen, again, is just trying to work overtime to break down these red blood cells. So it works so hard, that's when the spleen starts getting big. Same concept with the liver, and it can progress into a leukemia. So again, rare genetic kind of a neoplastic blood cancer, that's important to know. And secondary polycythemia is the most common type. So polycythemia, primary polycythemia, is also known as polycythemia vera, and it's caused by a problem with the bone marrow resulting in an overproduction of red blood cells. Secondary polycythemia is the most common type and is caused by an increased production of erythropoietin, resulting in an overproduction of red blood cells. Something is causing an increased production of erythropoietin, and with that, we have an overproduction of red blood cells. Seen in individuals with chronic hypoxia, people who live at high altitudes, greater than 10,000 feet. Here's where we see it a lot. People with smokers, then they have an increased carbon monoxide. And another group of people are men who are on testosterone replacement. Testosterone leads to an increased erythropoietin, which causes an increased red blood cell. And smoking and increased carbon monoxide in the blood versus oxygen, the kidney senses it and says, whoa, I need to make some more erythropoietin, increase erythropoietin, and increase red blood cells. Clinical manifestations of polycythemia are a result of increased red cell mass and hematocrit. We talked about that already, leading to increased blood volume and viscosity. This combined with thrombosis leads to symptoms of ischemia in vital organs. Okay, so again, pain, hypoxia, decreased peripheral circulation. There's just too many blood cells to get through. Circulatory alterations caused by thick, sticky blood give rise to other manifestations such as a plethora, which is like a red, ruddy color of their face and their hands and their feet and their ears and their mucous membranes. They're not anemic and white. They just have this red, ruddy look to them. An engorgement of retinal cerebral veins, so their veins are also engorged. Individuals frequently have an enlarged spleen with some abdominal pain because of the enlarged spleen and feel discomfort because that's too big. It's not supposed to be in there. Again, too many red blood cells. Spleen has to work overtime. And death from cerebral thrombosis is approximately 5 times greater in individuals with polycythemia. So that's something to keep in mind too. Evaluation and treatment. Blood and laboratory findings confirm the diagnosis. Diagnostic criteria include a hematocrit equal or greater to 50%. That's the best number to remember for a guideline. Like I said, it can vary depending on the specialty and man, woman, blah, blah, blah. A bone marrow examination demonstrates the proliferation of those precursor cells, those stem cells, and the presence of the JAK2 mutation, which confirms the diagnosis. Okay, so they take a look at this and they see this just proliferation of these erythrocytes, and they have the JAK2 mutation. Those can, well, that's confirmation of the disease. And this is just a picture right here that I remember if you go back to the test tube from the very first lecture. This is the normal blood. Here's your hematocrit down here, which generally is, 37 to 47%. And anemia, the hematocrit is less, which is the percentage of the whole test tube. And polycythemia, you start having an elevated hematocrit. Generally, it's getting greater than 50% right here. Treatment for polycythemia vera consists of reducing red blood cell proliferation and blood volume, controlling those symptoms that they have, preventing clogging and clotting of the blood vessels, and this is done by phlebotomy. So this is a patient who's going to get phlebotomy, 300 to 500 milliliters at a time to reduce their erythrocytes and blood volume, and they are on a low-dose aspirin just to prevent the platelets from clotting and sticking together because of all that stuff in their vessels. So recommended treatment is phlebotomy. Generally, when somebody's hematocrit is 50% or greater, they're going to get a phlebotomy. They're going to get phlebotomy, and they take low-dose aspirin every day. If they're at a high risk and they're having complications, they may be anticoagulated with the aspirin or in lieu of the aspirin. Hydroxyurea, a myelosuppressive, is the drug of choice. Sometimes they get put on this medication that we just talked about for sickle cell as well for a drug of choice. The last thing I'm going to talk about is iron overload. So this is too much iron. This person doesn't have too many RBCs, they just have too much iron. Hemochromatosis is caused by excessive iron absorption. There's a lot of iron in the body. Instead of storing it, it is getting stored and it's just getting absorbed in the organs. It's characterized by an increased iron absorption from the GI tract with subsequent tissue iron deposition, so it's getting deposited. Excess iron is deposited first in the liver, it's the main one right here, in the pancreas, followed by different heart, joints, and endocrine glands. Excess iron causes tissue damage that can lead to diseases such as cirrhosis, because that's the first place it gets deposited. Any type of chronic diseases, diabetes, heart failure, arthropathies, impotence, anything can manifest because there's just too much iron. So what happens is there's extra iron, and it gets deposited in these organs and tissues, and then the organs get damaged. And the main organ that it gets deposited in is the liver. So there's primary hemochromatosis and secondary hemochromatosis. Primary is hereditary. It is a gene mutation, and they're predisposed to having high irons, and so are their family members. So it's something that the family members need to get tested for as well. The secondary hemochromatosis is not genetic. It's something that we do to give the person too much iron, like, for example, somebody who gets too many blood transfusions. So with this blood, it's filled with iron too. So they can get it because of that. So secondary is not genetic. So remember, we had the red blood cells, 120 days they die, and then the iron is recycled, and the rest of the RBCs are broken down into bilirubin, and this recycled iron now starts to deposit in the organs, and that's the problem that these patients have. Clinical manifestations more common in men than in women. Fatigue and arthralgias are the most common symptoms occurring early in the diseases. They start getting these joint pains because the iron starts depositing in the joints, and that's when they feel it. The risk of cirrhosis is significant. Okay, so remember, because that's generally where it starts to deposit. And so they may complain of some right upper quadrant pain in their belly, maybe some ascites and some edema. Any of those can indicate liver failure or cirrhosis. Symptoms of a heart failure might develop because of all this fluid that's accumulating in the liver, and it's just a fluid accumulation could lead to somebody with a heart failure. Other findings include progressive increase in skin pigmentation because of the iron, diabetes, arthritis, hypogonadism. Most individuals are diagnosed as a result of elevated liver function tests found during routine screening. That's often how it's found, or somebody may come in already in a progressive stage with some symptoms like what we're seeing in this person right here. And then evaluation, serum iron and serum ferritin are the first diagnostics. Individuals with abnormal results should undergo genetic testing. Again, make sure that it's generally something with genetics versus us giving it to the person, like with transfusions. Phlebotomy, talking that again, is the first line of treatment with a goal of reducing the serum ferritin. Ferritin stores tin. Initially, phlebotomy may be needed weekly, but once the therapeutic ferritin levels are reached, phlebotomy may be needed only once every 2 or 3 months. Individuals should be instructed to refrain from drinking alcohol. Remember, the liver becomes a real problem here. No iron supplements. They should be avoiding anything with extra iron in them. Consuming raw fish or shellfish, which are high in iron. Vaccination against hepatitis A and hepatitis B is advised because it's a common cause of cirrhosis of the liver, so we don't want them to get hepatitis on top of it. And regular screening for the development of liver cancer is done almost at least annual for these people, even maybe more. All right, I think that's going to be it for the red blood cells. Thank you.